Welcome to AETCM, the Emergency Medicine channel. Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIIMS Kochi.
I'm Dr. Jerome Maurice, final year resident.
I'm Dr. Evin, a first year emergency medicine resident.
I'm Dr. Cecil, first year resident. I'm Dr. Pretty, first year PG resident.
So today we are going to present a case about a 22-year-old female who came to our ER with complaints of sudden onset of breathlessness and itching all over the body following an intake of oyster. Shall we start, sir?
Yes.
So here we were not initially aware of the history, sir. So the patient on coming, patient was coming walking actually. Patient came and initial 10-second assessment, the patient was conscious, talking and oriented, but on visualization we could actually feel the patient was little agitated. Some discomfort was obviously on the face was noted, sir. Coming to the airway, on initial assessment, on inspection, her face was little swollen up with her lips swollen, sir. And other than that, her whole face and actually her eyelids also was swollen, and little more lacrimation was also noted. That was regarding the inspection part. Then
Inspection of face.
Face, sir. Then on further inspection, like we asked her to open her mouth, sir. On in inspection, there was actually no obvious tongue swollen, or tongue was not swollen, sir, or uvula was also normal, sir. Other than that, her neck was actually
Basically, look, listen, feel.
sir.
Before the patient arrives, you should be ready with all.
We were actually all ready with our personal protective equipments, and we have also informed our team regarding the same, and the
airway breathing,
breathing,
circulation, everything should be assigned. All equipment should be ready.
And the crash cart was also ready, sir.
Okay.
And the neck on inspection also no obvious abnormality was noted.
If we had an idea that the patient is having anaphylaxis, in the first instance itself, you could have given one shot of adrenaline. How much?
So 0.5 mg, 1 in 1000 dilution, IM should be given either in the deltoid or
anterolateral aspect of the thigh is what is mentioned in the resuscitation, as per Resuscitation Council guidelines. Okay. So in airway, you're supposed to look for look, listen, feel. So you should be looking for anything. Airway means it's not the face. Secretions, swollen lips or anything. Airway is basically the tongue, because that is airway. You will allow those things. Okay, because at any time patient can have an airway compromise and lead to hypoxia and then cardiac arrest. So that is the importance. And then look, listen and feel. Listen for what?
You have to look for any. Initially, the patient can have any abnormal sound or hoarseness of voice. Then at a later part, we can have stridor also, sir, in anaphylaxis, anaphylactic reactions. Here the patient
feeling for. These will also be there, right?
Wheeze can be noted, sir. Wheeze audible, wheeze can be there.
Then feeling for.
Feeling for any subcutaneous edema or
chest rise, abnormal chest rise and all these things. The overall, you're looking like this, no? You're looking for the airway and breathing. In toto, you're looking.
Yes.
Is there any problem in that? Look, listen, feel. Okay. So what did you do at that point?
Here, the patient's airway was patent, sir. No obvious abnormality noted. Patient was talking also. And there was actually, in this case, there won't be any pooling of secretions and all. But obviously, in this case, there was no pooling and patient was fine, sir. Then in the breathing part is the problem here came, sir. Actually, in the breathing on inspection.
So, suspected anaphylaxis, immediately you, what position will you?
We can actually have to keep the patient in the bed, either in the propped up position or in the lying down position. should not keep the patient in standing position.
Okay.
In the breathing part, here on inspection, there was no obvious abnormalities noticed rather than the chest being tachypnea was there. So she was.
What was the RR and dispute?
Here the respiratory rate was 32 per minute with saturation of 96% maintained in room air, sir. And she was tachypnea was noted on inspection, and in palpation wise also chest rise was in the higher side, so tachypnea was present. And on auscultation, air entry was bilaterally equal, but audible wheeze was
normal. Percussion was normal.
Percussion was normal. Wheeze was present, sir.
Extensive wheeze bilateral.
Yes, sir. Here, as wheeze was there, she and from the history also, we got the history at this point. So we gave her here adrenaline was given, sir.
Here, anterolateral aspect of
anterolateral aspect of thigh, we gave 0.5 ml adrenaline 1 in 1000 dilution. So
that is the first shot.
First shot was given, sir. Upon we continue further with the.
So when should you consider giving the second shot?
We'll wait for up to 5 minutes, sir.
5 minutes. After 5 minutes, you start the clock and say after 5 minutes.
If patient is persisting to have any symptoms like wheeze is
second shot.
We'll
on
give
on the other
anterolateral aspect of thigh, sir.
So, okay. You noticed wheeze and you gave first shot of adrenaline. Okay. Then.
So further, we evaluated, sir. Here in circulation, there was no obvious. Here actually, circulation wise. Inspection wise,
what is the heart rate, BP?
Here the pulse rate was 112 per minute. With
heart rate
112 per minute. With
pulse rate is different. Heart rate is different. Heart rate is what you see in the monitor. Pulse rate is what you palpate.
And BP was 100 over 50, sir. 100 over 50 mmHg.
Okay.
And here all peripheral pulses were palpable, and capillary refilling time was less than 2 seconds, sir. And we also put an IV line here, sir. IV line was also secured, sir. And
blood samples
were initially we took the blood samples, but as the history of this was noted, initially for further analysis we should send serum tryptase level, sir.
Mast cell tryptase.
Mast cell tryptase level.
To diagnose it as anaphylaxis. That is required. Mast cell tryptase. In India, usually
we are not
we don't
usually
do
sending.
it, but if you go according to the AETCM guideline, at initial presentation, 0 hours itself, you should take the sample for mast cell tryptase.
And as
to prove the diagnosis of anaphylaxis. Okay.
Initial 0 level we have to take, and after 2 hours we have to take the second sample, and after 24 hours we have to take the third sample, sir.
Why is it like that?
So maximum level of tryptase level will occur after 2 hours, sir. Maximum peak level. So
starts rising after 30 minutes and peaks by around 2 hours.
Then it will, due to half-life being 6 hours, it will start to reduce, sir, and
by around 6 to 8 hours
it will come down. We can take.
So 3 samples have to be taken at 0 hours, 2 hours,
and 24
after
12 to 24 hours.
Okay. To see whether there is actually a increase in mast cell tryptase increase means it's a case of anaphylaxis. Okay.
Then coming breathing circulation was part done, sir. In the disability
circulation, no issue, not much of a problem in circulation.
No shock as such was noted, sir. In cases of shock regarding the adrenaline, in patients we had to give at least 500 to 1000 ml initially. In cases of children, we have to give.
If there is some problem in circulation, you start fluids,
sir. And
500 to 1000 ml.
1000 ml in adults, and in children you have to give 10 ml per kg fluid bolus have to give.
Here that wasn't
required.
Okay.
In cases where if IV fluid is also not helping in response of in cases of shock in anaphylaxis, we have to start on noradrenaline infusion, sir.
Not here.
Not in this case, sir. If at all the patient is not being refractory anaphylaxis cases, if patient is persisting to have shock, we have
suppose after 5 minutes you again reassess, and the patient still has got a hypotension. Any problem in A, B, C, D, or E? Okay. The anaphylaxis is a systemic Involves a systemic involvement.
Acute systemic inflammatory reaction involving IgE mediated.
Following a trigger. It's an IgE mediated
IgE
thing. Following a trigger, mast cells will release all these things. And then it will cause some problem in A, B, C, D or E. If at all you encounter some problem in A, B, C, D or E, you give first shot of adrenaline. After 5 minutes, you again reassess. And if still that problem persists, you give the second shot of adrenaline in the opposite thigh. If still after that, this thing persists, then you label it as refractory anaphylaxis. Then you move on to the refractory anaphylaxis algorithm. Right. Okay.
Here we went ahead with the primary survey. In disability, GCS was full score, sir. There was no confusion or any abnormality noted. And further in exposure, exposure was done. In cases of allergy, we should look for any allergens or any bite stings or bee stings. These can be noted our body, and we should be able to remove it. These things can again further increase the problems.
So how do you know whether this is anaphylaxis or whether it is urticaria or angioedema? How do you know?
So anaphylaxis will be having 3 points.
What is allergic urticaria?
Allergic urticaria will be having skin manifestation like itching or edema, swollen edema will be there, and it will be
usually superficial. It's also known as hives. Okay. Then?
Whereas in anaphylaxis, it will be acute in onset, skin manifestation will be there, and it will also involve either the airway, breathing, circulation, or a disability part here, sir.
So this urticaria plus either involvement of A, B, C, D or E is called anaphylaxis. Okay. And if usually it is always IgE mediated.
IgE mediated.
Whereas if it is not IgE mediated,
it is anaphylactoid reaction.
Anaphylactoid reaction. Okay. And angioedema?
Angioedema will be involving the edema of the subcutaneous tissue of either the mucosa or submucosa can be there, involving the face.
Usually it is bradykinin mediated.
Bradykinin mediated.
Angioedema. It can be hereditary angioedema or acquired angioedema, drug-induced angioedema, usually bradykinin mediated, and it's usually deep. And it may not be, like immediately, you may not get the manifestation, the swelling and all these things. And usually it involves one limb. Suppose his hand only will be involved, this edema will be in the hand only, or maybe in the face only, like that. Okay. It's not usually a generalized one. And may not be necessarily associated with itching. And usually it's very deep. It's not superficial like hives, urticaria. Okay, so what we are interested is basically in anaphylaxis. So other things can be dealt by a dermatologist. Okay. And the treatment is different for hereditary angioedema and all these things. Treatment is different. What is given?
Hereditary angioedema occurring due to C1 esterase inhibitor deficiency, sir. So we have to give FFP, or else we can give like C1 esterase inhibitors. Also we can give like bradykinin, kallikrein. This can be given, sir.
Okay.
Here exposure was done, sir. Further, we went ahead with the secondary survey, sir. So, secondary survey sample history. So, here there are
Suppose this patient, you gave 2 doses of this thing, he didn't improve.
After second
dose of adrenaline, still the symptoms are persisting. You move on to the
third
refractory anaphylaxis algorithm. So how do you deal with the refractory anaphylaxis?
So after second dose, we will again wait for 5 minutes, and still if the patient is persisting to have any of the symptoms, we will start on infusion, sir. Adrenaline infusion will start.
If infusion is not available,
we can further give bolus doses.
Further dose back to back,
we can give, sir.
Yeah.
Once till we are able to give the infusion.
Okay.
Here the adrenaline infusion we can start
a low dose adrenaline infusion you can start. Okay.
1 in 1000 is mixed with 100 ml of NS, and
1 mg of 1 in
1000 is mixed with 100 ml NS.
And given at
can be given at like
0.5 to 1 ml
per kg per hour.
Okay. And if on reassessment, if there is a problem in airway, if you find stridor is persisting in airway, what will you? in the refractory anaphylaxis algorithm.
We can give adrenaline nebulization can be given, sir, in
Adrenaline nebulization.
refractory cases. Whereas in breathing part, if persisting to have wheeze, we can
when you move to B, if there is a problem in B, suppose if there is a wheezing, you give
nebulization, salbutamol or ipratropium nebulization can be given, sir.
Okay. And if there is a problem in C,
See that initially we will give fluid boluses if a patient is persistent to have
up to 5 liters, 3 to 5 liters you can give. If still it is there,
we can start on noradrenaline infusion, and if still patient is having the same thing, we can go vasopressin also can be started, sir.
Metaranol, some things are there. Okay. And what about if the patient had a consumed beta blocker
In cases of beta blocker,
and the patient develops the same symptom, what will you give?
we can give if initially we will give the adrenaline for anaphylaxis, and still if the patient is having persistent anaphylaxis, refractory anaphylaxis, we will give.
So regardless of whatever the precipitant is, whether it be beta blocker or whatever, the first drug of choice is always adrenaline.
Adrenaline.
This glucagon
Will be
thing
given
not be
refractory anaphylaxis.
You can consider glucagon only in the refractory anaphylaxis algorithm after giving all shots of adrenaline plus adrenaline nebulization, everything, noradrenaline, vasopressin. So this is the last resort, giving glucagon. Immediately you don't give glucagon for any case of beta blocker, this thing, causing anaphylaxis. Okay. Continue.
So sample survey, she complained of signs and symptoms. She complains of breathlessness, generalized tiredness, nausea, chest discomfort, itching, following intake of oyster 1 hour back, sir. Allergic history, there was no any allergic history, no medications as well, and there was no significant past history. Last meal was like 1 hour back where she consumed the oyster, sir. And events was same as described, sir. This is regarding the secondary survey, sir. And
so this being an event, you should be following that who approach. Who saw it, where it happened, when it happened, all these things. What all happened around that thing, and then past history is important because usually allergy, anaphylaxis and all will have a past history of this thing. So after HOPC, addressing all HOPC, you'll have to mention in detail. Not only this, you'll have to mention completely what all things happened, the who approach, who, where, when, why, how, what, all these things. Then address all the 8 systems of the questions pertaining to all the 8 systems. Then the past history, whether the patient already had a previous history of anaphylaxis and things like that, what was done at that point of time. Does he carry a EpiPen with him? EpiPen is what?
EpiPen is like adrenaline, which is given with patients, injectable pen. We can give that under side. Okay.
Then family history, social history, where he's all these things you'll have to take for completion's sake. Okay. Then
here upon reassessment, the patient's wheeze subsided, sir. After the initial shot of adrenaline, after 5 minutes, upon reassessment, her symptoms subsided, sir. And
with one shot.
One shot.
So what is your plan now? Patient is completely okay after the first shot of adrenaline.
According to ARCAN guidelines, if the patient had adrenaline and anaphylaxis and we given a single shot of adrenaline, we can discharge the patient after 2 hours, sir. In case where if we are given with
EpiPen and things like
with EpiPen or any other adrenaline pen for
nowadays the new guideline is nebulization is also recently 2 days back FDA has approved
2 days adrenaline nebulization can be given, sir.
They have approved it. Okay. Then if after two shots only the patient improved, then what is your plan?
We had to observe the patient for 6 hours, sir.
If the patient had some severe respiratory compromise,
we had to observe the patient up to 12 hours, sir. 12 hours. Once the symptoms are subsided, from that point onwards, 12 hours we had to observe the patient.
Yes. After resolution, 12 hours after resolution of symptoms, you will have to monitor the patient and then only discharge. Okay. That's all.
Uh,
Anything, any clarifications or something? So that is about management of anaphylaxis as per the Resuscitation Council guidelines. You can just Google it, find in, it's a March 2022. It has been released, Resuscitation Council guidelines. Okay, thank you.